Today we'll be talking about MIS navigated TLIF or MIS concepts in general. We have the highlight of having some additional technology because this is kind of a smorgasbord of new technology in spine. So I asked them to just pull the robot in so we can kind of add that to the overall workflow. I've been doing navigation since 2008 when I was a spine fellow with Pat Johnson. We had probably the third or the fourth O-arm in the country. And since then, it's just been one of these things that it's exploded into a technology that really provides everything we need, increases overall accuracy, improves the overall, I think, performance of a surgeon. And one of the latest things that we'll be talking about during this section is about learning curves and workflow, and the idea that navigation really is starting to free up the surgeon to kind of think about other things than just the surgery itself. So before, the concepts were really kind of make sure your screws are accurate, a lot of mental effort to make sure things are exactly where they need to be. Navigation with pre-op planning and some of the things we're learning with workflow is really taking a lot of that out of the surgeon's mental mindset. And that allows you to continue to focus on other things and fine-tune the overall surgery that you give for your patients. So I have a couple slides that we'll just keep going back and forth on. I don't know who's driving the stand up there, but if next slide. I am a consultant for Medtronic and DePuy Synthes. Next. So when I first started MIS navigation, it was a lot more perk screws. I was a big open MIS TLIF guy, two-inch incisions midline, quick, and this was probably close to one of the last things I had, navigation that I adopted into an MIS TLIF. But the value of incorporating navigation into your MIS practice there's a lot of positive points. We talk about the high grade of accuracy. And one of the most important things with navigation in MIS is you don't have visualization of the deep bony anatomy. All you have when you're talking about MIS is a lot of skin. You're working through small portals, and so it only complements that visualization for the surgeon to really kind of understand what's happening. Unlike an open deformity where you can check the bony anatomy, check where you're going, navigation seems to be that added layer of complement. Remember, I was talking about taking the surgeon's attention away from really kind of determining if it's accurate or not and allowing the surgeon to really think about other things. That's what navigation has done for me in MIS. So clarification of deep bony anatomy. And then one of the biggest things that has driven me since the beginning was this whole radiation exposure to the surgeon and more recently to the patient. In residency and even during fellowship, there was just a lot of beeping of the fluoro machine. So a lot, you would look at the end of a one-level TLIF case and we're talking like 3 or 4 minutes of fluoro, all those cumulative one-spot shots. You're literally watching the TLIF graph go in millimeter by millimeter as the attending is saying shot, 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 shot. And so all those things, all those radiation, the scatter radiation that hits the surgeon, in addition to the patient, that's another kind of added value that always is not as highly talked about, but certainly is important for your entire surgical team. So next slide. The reason that I wanted to wait on navigation is because I couldn't understand just how to get it efficient. When you're running an hour and a half, one-level TLIF, it's hard to add an imaging modality that won't slow you down. And so there is a certain kind of learning curve period where it delays you from doing what you normally traditionally do. But if you adhere to a lot of the concepts of navigation, which is work on your workflow, really pre-plan things out. Over time, the efficiency gets better and better to a point where you actually are about as quick as a open TLIF. I would say my open TLIF fluoros are still a fair amount faster than navigation, but when you add in all the value of the increased accuracy, the radiation exposure, that 5 or 10 or 20 minutes of savings of OR time really does kind of lose to all the additional benefits of navigation. So that's kind of where I'm at right now. I've done over 100 MIS navigated TLIFs, and definitely getting to a point where things are very smooth. Next slide. So today, usually it's a slide and me just going over things, so I kind of wanted to show you more hands-on. And these are one of the last couple slides that I have. This is the room setup. This is my poor scrub tech that we put on a Jackson table, and usually in a prone position for MIS TLIFs. The arms are tucked in the side so that the imaging modalities and whatnot can slide up and down. We don't alter the table height or position after the image capture is completed. So there's no, once you capture the spine with your 3D fluoro or your intraoperative CT scan, you don't mess with the table positioning or in any way. You click the button. Keep going. When we talk about, we'll talk right now about workflow and where to put everything in the room. The camera either goes at the head of the bed or the foot of bed. Next slide, or next. And the intraoperative modality, whether it's the fluoro or the CT scan, keep it in the room. That's a workflow issue where if you need some kind of check or you lose accuracy, you want it there in the room. We'll get to this slide in a second, but just to kind of go over reference frame. I don't know if there's a camera looking from the top. Good. Fantastic work by the way, guys. This is why I love coming to Seattle Science. This is the overall setup. So we're using today BrainLab and DePuy Synthes instrumentation, and really the concepts are still the same when you talk about overall workflow. You want to know how your patient is being positioned, but after that, where your reference frame goes. This is probably the most important concept in making sure that the rest of the surgery goes along smoothly. In general, most systems of navigation have two types. There's a spinous process clamp, and there's a pelvic pin clamp. Initially, we were doing a lot of pelvic pin clamps. I moved away with it to spinous process clamp that goes more here. Now I'm moving more back to the pelvic pin clamp in this orientation. So this is the midline right here. This is the gluteus, or the bottom of the patient. This is the top of the patient, just to give everyone orientation, midline, lateral, medial. And if you look at these pelvic pin arrays, whichever the case may be, you're putting them in from a lateral to medial position. If you can zoom out a little bit. You're keeping it away from your incision as far as you can. But because it's midline, and zoom out a little bit more, you can see that the array kind of goes midline and stays away from your operative field, which is right here. And then what we see, if you look at the actual room, the stealth station is at the foot of the bed. It's down here, and it's looking at the reference frame. So from the reference frame to the camera, there is absolutely no, if you can move that camera a little bit more and show them where the stealth, there you go. There is absolutely no block of anybody here in general. You don't have an anesthesiologist's head poking around. The scrub tech is usually next to you or behind you. And this line of sight is the absolute most critical part of a successful workflow, line of sight, making sure that no one's in this way. This doesn't get bumped. There's no blood splattering over here. And I like this aspect of BrainLab where it really moves things out of your surgical field so that you can stay stay focused on this. And so once this gets set in, these perk pins are put in just like if you were to put in a pelvic bolt, an iliac bolt. It's from that under the PSIS aiming towards the greater troch or into that teardrop region outwards. And they're 2 pins, very rigid construct, and once you secure all the moving, articulating pieces, it allows variability, then you're set and you're done. Let's move on to the actual screen. Can they see the screen, the Zeem? Oh, yeah, the navigation Zeem screen. I don't know if you guys can see this. So this is a CT scan. So let's show them the CT scan first. This is the cadaver. They kind of got a CT scan of the cadaver, deep bony anatomy. That's the Zeem, actually. Oh, that's the CT. Okay, so side by side, if you're looking on that top, for me, it's the top left corner. What you're seeing is the high detail of the CT scan. And today, what we did instead is we used 3D fluoro, or the Zeem 3D Vision 3D fluoro on the opposite side. So on my side, it's the right. You're looking at the axial slices right there. Ignore the lower coronal and sagittal reconstructions, but this is kind of the side-by-side comparison. And so when you talk about different types of imaging modality, which we'll get into today, whether you need, when you see a pedicle that's like a 10.5 or 9, Johnson would put a 9.5 screw in. But when you see that on a CT scan, do you need that amount of detail to be able to put a screw in? And when you look at the potential costs and benefits of 3D fluoro and the versatility of it, can you work with that? And so that was kind of one of the first things I wanted to highlight from an imaging standpoint with MIS for a lot of people who still have Zeem fluoros. You can still achieve the same concepts. When you're talking about more maybe higher level stuff like deformity, big, accurate, wide resection tumor dissections, it's probably more beneficial to have more of a CT scan that shows such high definition, all the cortical margins and whatnot. But just kind of a point of imaging options. The reason I also bring that up is, as you can tell on this BrainLab software, it is vendor agnostic, and I like how they use that word agnostic. Really kind of brings something emotional in you. But it literally can apply to any instrumentation system, any imaging modality. They are a software company, and so you can feed whatever hospital you're at, whatever kind of unique imaging modalities and or instrumentation needs. It all kind of goes together, or it's all compatible. So today we're using it with diffuse synthese, but this can work with other companies as well. It also works with intraoperative CT scan images. It works with preoperative CT scan images. And I said today we just acquired the 3D fluoro before everyone walked in. And that certainly that's an added benefit to just add that in instead of creating a whole new workflow process. So then if we go back to the actual image of the cadavers, and then that view on the top. This is the basic navigation Teal F surgery. There's nothing more than this. You have your perk pins and you have your 2 Wiltse incisions. You don't need a midline incision for the decompression. The decompressions can be all done through these Wiltse-based approaches. But always, or at some point, you're going to decide which side you want to go in for the TLIF, which side is the more symptomatic radiculopathy side. So in this case, if this is the left side and this is the right side, we selected a right-sided TLIF approach. When we talk about the overall workflow, and can we go to the PowerPoint, back to the PowerPoint, Dr. Johnson or Danielle, who's ever running the stand. The workflow needs also to change when you're incorporating navigation robotics into MIS, right? Because initially with an open T-lift, non-navigated, you're putting screws in first. Once the screws go in, then you do your decompression. Once you do your decompression, then you do your T-lift, and then rods. That workflow needs to be revisited revisited, revised, and changed completely. So that when you're using when you're incorporating navigation, the navigation part goes first. So the first 3 steps are you place your reference frame, you acquire your intraoperative CT scan, and you verify all your navigated instruments. If you can next click. And that's just acquiring the images. The hardware or the instrumentation then becomes, you put in your contralateral pedicle screws. This is more from the open MIS techniques with fluoro, but you put your contralateral pedicle screws. So on this side, in this case, the left side, pedicle screws in first with the MIS towers. And then on the side that you're going to do your Teal F, you put in guide wires and the tubes. And so there are certain screw systems that are modular, but in general, if you put your MIS towers in here, then you have a big traffic construction zone where you got T-lifts, towers that are interfering with your T-lift introduction system and your tube, and so that kind of gets kind of hectic and busy. So in my practice, we either save the position with this guide wireless software, or you put in guide wires and you just kind of bend them away, and that allows you. So part 2 of that workflow is to put your contralateral screws in first with the MIS towers, no rod yet, and then just put the guide wires in, tap it, but don't put the screws in. Once that's done, then we move on to the decompression discectomy. And this is not through a microscope approach, but usually we have a tube, and through the microscope, we're doing our usual TLIF. And there's nothing special about the decompression or the TLIF with navigation versus open. At the end of the day, the success of navigation or open TLIFs in general is successful decompression of the neural elements, which is why you're there in the first place. So you really have to do that well. And out of all this new technology stuff, that is the most critical portion, and especially the proximal portion of the exiting nerve root. Really have to get that decompression well done in order to make sure the patient is clinically happy afterwards. So then once the guy, so going back, we're doing the decompression, did the facetectomy, removed the superior articulating facet tip. We're looking down, we've decompressed the neural elements. Through this tube then, we have, again, navigated instruments. In BrainLab, everything is navigatable. So do we have a navigation screen to show them too? So I'm putting this osteotome down the tube. And I guess one thing I should highlight is that any instrument, so if you even have a random non-standard TLIF trial or whatnot, you attach a little array to the shaft of the instrument, and then all of a sudden this becomes navigatable. So there is literally no instrument, Cobbs, curettes, whatever you want, Kerrisons. There's nothing that's not navigatable by just clamping it to the shaft, as long as it's a rigid, fixed device. They have capability to understand the length of this and navigate it as such. So that's what we did for this navigated TLIF spacer. This is just the standard stuff we use for open, but they attached a little array and now it's navigatable. The osteotome is built-in navigated. And so through our tube, as I'm putting it in, you're seeing that it goes right in. One point that I wanted to highlight with navigation also is that it's not pre-op planning, but it's judging your incisions. That was an issue with open Wiltsy kind of fluoro T-lifts, is that sometimes the incisions would be too lateral, sometimes they'd be too medial. The ability to really kind of understand from the skin level, so you can see my osteotome right now is at the skin level, to understand where does this incision need to go? Does it need to go way lateral in order to get in? No, this is too lateral and I'll probably hit the psoas or the exiting nerve root. If I'm too medial, which is commonly what's done in fluoro accidentally, then you're really pulling on the tissue hard to get your lateral to medial trajectories. So it's all about kind of pre-planning from an intraoperative standpoint and really understanding, okay, this is by the way, we're doing 3-4. This is the 4 trajectory, this is the 3 trajectory, and then how do we, and then the TLIF trajectory. So then from the skin level, just understanding where my TLIF is going to go. And this is kind of the stuff that I do before I even make that incision. I'm looking and I'm saying, okay, this is probably, when you look at that white line going all the way to the disc, that's probably where my TLIF will end up. Am I happy with that in relation to where the disc space is on the sagittal, in relation to where I have to put the screws in? But if I am able to just fire things straight down here, straight in the level of the disc space, then there's not a lot of tube movement. And that was another problem with non-navigation, was that your tube, you would constantly be loosening your tube arm and moving it more medial or sliding it more lateral. You'd have to loosen this as your instrument's here, and you'd shift everything back and forward. You don't need to do that anymore. Everything is just more or less a one-pass scenario. So as we insert it in, this is, again, just going through the tube. There's not a lot of wiggling or movement. You go in with your osteotome, and you essentially rotate it, kind of open up the disc space, and then do your disc prep. But again, maintaining that everything is in the same trajectory. There's not a lot of movement. Once that goes in, you do your disc preps with your various kerosins, your pituitaries. And what's interesting with TLIFs is when you do a lot of them open, you can almost, the one knock on navigation in general is it doesn't dynamically follow everything. It doesn't dynamically track movement once you've gotten the spin. So if I were to put this TLIF graft in, I wouldn't necessarily know the movement of the spine or where the next iteration is supposed to happen. But that's what we find is that navigation can, especially with these navigated interbody grafts, you can really understand where you're putting in your final implant. And so then, assuming that, again, this is your final TLIF implant, you just kind of tap that in once the disc prep is done. You put it, another difficult part of non-navigated TLIFs is understanding where the anterior posterior, where the ALL ends, so that you don't shove it right into what appears to be the aorta or the on that axial cut. But you're inserting this right into its final position. You like where everything is going, and then you just unscrew your instrument, leave the interbody graft. So it's not, if you think about it, it's not a real-time visualization of where the final implant is, and you can always obtain that with a final fluoro AP lateral or the intraoperative CT scans all have fluoro capability. You can get a final one just to be sure, just to make sure. But in our practice, we kind of are able to see it. We're able to visualize where the annulus is and how deep it is, and that it's accurate. And that finishes the TLIF part there. Next, so once the TLIF grafts are in, then you take your tube out, put the screws in. One of the things I wanted to highlight, so if we can, how much time do I have left? Probably gone way over. Highlight was the actual BrainLab Circ robot. So if we can zoom out a little bit. I don't know if we can or not. Okay, so this is the Circ robot. It's attached to the bed frame. It's 22 pounds, super light when you think about the extremely big robots that come in with a big stand and frame. It is one that, again, attaches to your table. You can put it anywhere. In this case, we just put it side by side by me. If I had my way, I'd probably put it on the opposite side, because ultimately what is a robot at this current standpoint? A cobot is basically your assistant, your resident, your fellow, someone that's potentially helping you with this process. So probably the robot would be more on the contralateral side. But it also, again, is completely agnostic when it comes to imaging. It will run off fluoro, it will run off intraoperative CT scan, preoperative CT scan, whichever company you want to use. And that's kind of the highlight of BrainLab in general, is all their instruments, whether it's robot or implants, or whether it's navigation, is completely agnostic. This is one of the earlier generations. They've done many more generations or iterations since, a lot more automation. Remember, in the beginning, everything was just stay and hold for robots. Now, with preoperative planning, preoperative CT scans, you can predetermine where your screws are, and the robot will follow the trajectory. But you can see that you press some buttons, and I encourage you all to come check the robot out, the BrainLab robot out. It's literally, you know, one finger or two fingers that you're just touching these black bars. That unlocks it, and you can move it all the way around over your head or wherever, and then you just click it twice to stay and hold. So in this case, then, as we are firing screws in potentially, and again, the order of this is probably not ideal, but for time purposes, you would want this, you would ultimately find your trajectory. And if we can go back to the navigated screen. Yeah, let's see if we can capture that. Okay, so then find little movements to, the newer robots will find the ideal trajectory, so it'll do one of those kind of small little movements. It'll match the preoperative imaging or preoperative trajectory that you have set, which is always nice for, again, taking the surgeon's mind off of having to worry about exactly where the starting hole is and how your screws are going in. When that is offloaded, it frees us up to think about more important things or other more pressing issues that we wouldn't be able to. And then ultimately, with this particular model that we have today, it's got a set guide point, so you can determine how far or what the depth needs to be. It's got a drill cannula. You put in your drill, it goes in through the cannula. You put in the ultimate screw, so you take this off like that, and then you're able to fire in your potential screw, which we don't have right now, but you would ultimately then just fire the screw right through the cannula, right back into the trajectory that you selected. So very cool stuff, very low profile. At the end of the day, I encourage you guys all to come out and check out every aspect of our technology today. But when you're really trying to become the next iteration of new technology and trying to better the techniques that you already are doing well, this is why I imagine a lot of you are here, and this is the technology that will take us there and into the future. So thank you, everyone. I'll see you in there in a short while.